to everyone, and welcome to this webinar on demand and capacity. I'm Richard Lendon,
muted,
and I also work with NHS IQ on a more central basis. I thought I'd start with a little story about a practice I visited just at the end of last week, actually. Practice essentially sees all their patients that day. So everyone rings up will be seen that day. They very rarely have to roll anyone any other day. And they do this by blocking off all their appointments because they've designed their system to work that way.
Has the conference.
They've had central input. They haven't done PGP. They've had no input from us or from anyone else. They've come across this system quite well. And the overriding thing I remember from the day was when they said, we basically decided that we wanted to do today's work today. So they don't have designated half days, but if they're quiet, they will decide whose turn it is to have a half day. But if they're busy, they'll tend to start early. But we all think that this whole problem of demand and capacity is totally solvable. But they've managed to do it, and they increase their resources. They've just come at it the right way.
John Howell. The conference.
What I've done with this presentation is that I've split it into 3 perfectly formed segments, and I'll be pausing for questions after each one. First of all, I'm going to look at what do we actually mean by the terms demand and capacity and what queues form. And then looking at how we actually manage those queues and some of those principles can actually make matters worse.
Joined the conference.
And then finally, we'll look at some of the more generic principles for dealing with the underlying problems.
Colin.
Joined the conference.
We've all been used to waiting. Okay. Sorry about that. Okay. I've disconnected off my own computer there. I've just seamlessly or not transferred onto another computer. Sorry. We've all very much become used to waiting in the NHS. We're very used to having queues, waiting lists, and delays, and our patients have really become used to that, and we've trained them quite well in that essence. Of course, though, this affects both the staff and the patient experience, and it also has a direct effect on quality. Patient safety, as we know that when
joined the conference. Has joined the conference.
Has an effect on quality and patient safety, as we know that the patient's clinical
joined the conference
is worsening as they wait. We're continuing to inform that demand is rising and capacity is required. We need doctors, more nurses, more kit. But is this always correct? Why do queues form in the first place? We actually understand what the terms demand and capacity are. Do we know what our demand is? But what is fairly clear to myself and most of us is that we need to gain a much better understanding of the problem before we attempt to solve it.
Has joined the conference.
First of all, I think we just quickly try and clarify some of the terms here. So first of all, I like to look at this in terms of
has joined the conference.
First input is this river of demand, and demand is simply all requests for a service from all sources. It's what we should be doing, and that goes into a lake or a reservoir, which is a waiting list essentially. Waiting list, or queue, is what we should have done. It's work that's waiting there. And out of that reservoir is another river. It's the river of capacity, and capacity is what we could be doing. All being equal, everything working perfectly, it's what we could be doing. Of course, everything is bottlenecks, and there's always a rate limiting step. So what actually comes out of that reservoir is activity, what we actually did. And of course, bottom of that reservoir sits the patient, and the patient experiences delay. So just to summarise quickly, demand is what we should be doing, what we could be doing, activity is what we are actually doing, and backlog or a queue is what we should have done. And people talk about having a demand and capacity problem, but they only tend to collect activity and backlog data, waiting list data. It's easier, it's there. We know how much work we've done, but we don't know how much we should be doing and how much we could be doing. Why do you use form? The usual thing that we all hear, and the usual theory, is that for a queue to form, demand must exceed capacity. But is it more to do with a mismatch between demand and capacity? I like to have queues because they make us feel busy, better utilised. And we all know that if capacity is not fully utilised, it's deemed to be of a waste and is often taken away from us. So let's look at those in a bit more detail. So demand greater than the capacity. I mean, if demand is truly greater than capacity, then queues would continue to increase. Little evidence for this. Our queues are not going up and up. They tend to move around a bit, but they're fairly static in most places.
Past the conference.
So variation. Demand is not constant. It varies by hour of the day of the week, by age, by sex, by the patient. Ways. Capacity also varies. This variation and the mismatch between the two that generates the queue. On the two are equal, but the variation in the two
joined the conference.
So, even if the average capacity equals the average demand, the variation in the two will cause a queue. And there are plenty of models we can use to demonstrate this, and it's fairly ideal in sort of queuing theory. But if we actually go away and measure our demand capacity, then it's our capacity that generally varies more, with holidays, study days, half days, etc. And as capacity is mainly under our control, our queues and waiting lists due to the way we run our services. And it's a really fundamental question. Actually causing our own queues. Therefore, why do we talk so much about demand management when the capacity is the bit that's under our control? I'll just pause briefly to see if there's any questions there. If anyone wants to ask anything at this stage, otherwise I will press on. If anyone wants to put their hand up or questions in the chat box, then we'll take them now. Okay, fairly happy? I will move on in that case. So we'll look at how we actually manage the queue, and often how that actually makes it worse at the moment. So today we just apply pressure to all our staff. We've done various forms of performance management. We bring in decision making, often based on poor data, on guesswork, often purely on anecdotal numbers, and we start cutting costs as well. Conversely, all these things we're doing actually lead to making things worse. Our quality drops, we often get increased costs, and a totally demoralised staff. And because we really understand why there is a queue and we don't diagnose the underlying issues, then we're really able to treat the problem appropriately. So what are we actually doing to manage the queue? Well, we often do things like waiting list initiatives. We've all experienced of doing those. We employ locum doctors, extra nurses, we work overtime, but this is never sustainable. And booking is where we already have full surgeries, full clinics, so we get extras. And again, staff become stressed, patients become annoyed because they know they're being pushed in to fit in. Not sustainable. We use batching. We make the patients wait. So instead of making our highly our expensive bits of kit, making those to wait, we make the patients wait. So we tell patients all to arrive at 9 a.m. I remember very well going to a fracture clinic when I was at university, being given an appointment for 9 a.m., thinking I was dead clever. I got there at 8:45, so I wouldn't have to wait too long, and got seen 3 hours later because the whole population of Birmingham had arrived at 8:45 or before me. The fourth way that we tend to manage queues is by carving out capacity. Carve out or ring fencing is where we reserve a section of capacity for a selected group. But this isn't on process, but on perceived need. So it's in many different ways. We reserve capacity in many different ways. Even session working is a carve out of time. We see surgeries, fixed surgeries, say 9 to 12, 2 to 5.
Tom and David.
Fixed,
has joined the conference.
We carve by urgency, like the 2-week wait, urgent soon routine, on the pre-bookable, and extras. All these are carving out capacity, splitting it up into separate units. We can carve specialisation and condition. We can set up diabetic, coronary heart disease clinics, asthma clinics, and there's ways in which we can carve out capacity. And carve out is an obvious or known solution. If we have a queue, it seems very obvious that we have to prioritise certain groups of patients and put them first and save them some capacity. But it generally makes the situation worse, and you can show this very simply with modelling. This is out by experience. And the effect of a bus lane. If we were part of the tarmac for a certain group of vehicles, does that will hinder the traffic? And we have roughly divided patients into urgent, soon, and routine. In A&E department, we'll not have resuscitation patients, major, minors. In fact, we'll have on-day patients, pre-bookable appointments, and extras. The more groups you carve out, the less efficiently you use your resources, and the longer patients have to wait. So can we reduce the numbers of queues rather than increasing them? So I said, carve out is a known solution, but counterintuitively, it actually makes the problem worse. It is quite important to recognise the difference between pulling out, ring fencing, and citation streaming. It's not based on process and interrupts the flow of all patients. It works the wait. Segmenting considers the process and flow more constant. They improve the wait. So, for example, a food clinic is a segment, is a stream. These are issues that can be dealt with very quickly, which is why we do those big flu clinics on Saturday mornings. And there's many examples of streams. So, again, I like bringing this back into the real world. Just trolley and basket queues for a minute in the supermarket. Is that a carve-out or a segment? I'll leave an open question. Queue is quicker. We've looked quickly there at how we traditionally manage our queues and how this can often make the situation worse. So I'll just stop for questions there. Some asked there, is carve-out ever useful? And effective are probably a different words here. A carve-out is only really useful if it's actually a stream. So if you start reserving appointments for a certain group of patients, which is based on the process that's going through the system, but it's purely based on a sort of perceived difference, then it will hinder the system. So it's important to think about carve-out and queue. So going out appointments, coding appointments is a carve-out. So most time carve-out will hinder things. If a string or a segment, then it'll probably make things better, and therefore isn't a carve-out by definition. Hope that's a little. Any other stuff or questions at all? No? Okay, I shall move on then in that case. So, in this section here, I think we'll begin to look at how we actually should be improving the system for our patients and staff.
Left the conference.
And what I've got here, I'm not going to give people any answers. I have silver bullets in my pocket here, fortunately. And some generic ideas than absolute solutions, but the things we should be thinking about doing. So for modelling, again, from experience in many different sectors and scenarios, it's fairly well recognised that if we set our average capacity at 80 to 85%,
has joined the conference.
Fluctuation in demand, then the queue is kept minimal. In the scenario, there may be some waste, but at least bad. What we intend to do, though, is set up our activity or our capacity at 50% of what our perceived demand is, and that will generate a queue. So we need a bit of flex in there at 80 to 85% of it, which will lead to some waste. So we can set the capacity at the right levels, or we can fix our capacity to meet demand. For example, demand tends to be higher on Mondays in general practice. So we need more staff on Mondays. We know it's predictably high after bank holidays, so we need to have more on after bank holidays. Now, the increased demand in general practice on a Monday isn't due to the patient at all. People are not ill on Mondays, but it's due to the way we run our systems. The NHS largely closes at the weekend. The primary care, so we have a surge on a Monday morning. So capacity is under our control, but demand isn't. Therefore, we initially concentrate our efforts on the factors under our control before looking ways to actually improve demand. But again, most of the time we hear about inappropriate demand management. But let's get our own house in order. Let's sort out the capacity issues and then look at demand. One of the keys is really to start looking at variation and reading variation, because I think it's well recognised. We all know that the more variation you put into the system, the more ineffective it is, the more clunky and cumbersome it is, and that can lead to quality and safety issues as well. So things like simple process redesign, process mapping, leading to a reduction in complexity and a reduction in variation in the way we work. Forms we have to fill in. Are they when you go to different practices, have you got different forms all over the place? Are the rooms set up differently everywhere? Just simple the way we work. Reduce variation. Carve out and ring fencing I've talked about. The more we can reduce that number of queues, that number of counts, the better. And then we can pool, and this is the Dear Doctor letters that we all use now. And again, smooth flow with appointments and admissions. I was at practice, I think yesterday, where all their appointments are 9 to 12, or 2 to 5. Every GP. No flexibility, none earlier, none in later, none in the middle of the day. So can we smooth those out a bit more? We know there's a surge of admissions to just lunchtime, and that's because the GP do their visits then. So again, if we could if we move the appointments out, perhaps we can smooth out the way visits are done, and therefore out admissions. Again, so reduce batching. We'll go off and do our visits together. Some practices will find 2 or 3 doctors at the same nursing home at the same time. It doesn't make sense, does it? We reduce the variation capacity, because as I said earlier, it's the capacity that varies more than the demand, so we need to be looking at that first. So there are ways that we can actually gain or increase capacity, and it's not just by putting more resources in, but by releasing resources from the system at a time unnecessarily. So if we reduce complexity and carve out, we'll often use some capacity. So reducing the number of appointment types and the complexity of that will release capacity. Can we work differently? Redesign flexible hours, weekend working, annual leave planning. Again, it all smooths things out, which release capacity. More active scheduling of appointments, or all the way, even things like reducing DNAs. That's decision in the system. And really be looking for more resources or more kit and more staff. And we know that the constraint is kit and staff. And working differently really will help. And in order to know that the constraint is kit or staff, we actually measure. We need to know our demand. We need to measure our capacity. We need to know what the demand on our service is. And in places we don't. So again, this is where we can reduce demand. I don't like this term demand management. I don't like it. It always sounds like we're trying to control the patient, tell them when they can be ill. As I said times already, look at first, then demand. So with demand, what is the most appropriate way to deal with our patients? And we're not about them here when I say deal. We're talking about where should they be seen, who should they be seen by, and how should they be seen. So it might be, are they better off seen, perhaps optimally seen at the pharmacy by a pharmacist, and how? Can we email? Can we use web more? Can we use things like phone consultations more? Simple things like. Do we need to see all the patients?
Left the conference.
Can we implement clinical and procedural protocols that actually avoid frequent visits by patients? Actually save appointments, both doctors and nurses, and again, simplifying the patient pathway. All these things will release capacity into the system. And then follow-up. And obviously, patient education and health promotion. There are patients who are frequent attenders. So educating and promoting health in them can help. And of course, if we're not sorting out the problem of demand and capacity, reducing waiting lists, reduce the demands that they create, thus reducing capacity. So we spend quite a lot of time managing our waiting lists, having to test results up admissions, patients ringing us up asking, having to ring up twice for the same appointment. All this work generated because of wait. If we reduce the wait, they will ring up less. The generic things we need looking at. There isn't one solution for all. It requires a lot of thought. But if you remember that the root cause of delays for patients is variability, not volume. It's not demand, it's variability in the demand and the capacity. And we gate most of that variability. So we need to reduce variability, creating a steady flow of patients through the system, and this will reduce delays. I've had a year or two, a lot in the press over that the reason A&E performance is getting bad. There's a lot of pressure that there are more and more A&E attendances. And you hear that's the GP's fault because they're seeing more and more there, or they're open less and less. This for A&E attendances and acute admissions into our acute trusts is unchanged for the last 4 or 5 years. It's not back it up. But because things are getting worse, we blame demand. We always drop back to blaming demand for everything, and it isn't the problem in a lot of places, or it's not the problem in most places. So really, just some key points here. we really need to measure and understand demand. We need to know how much healthcare we need to make. It's the same, I know, but Tesco's and Sainsbury's and wherever, they know what their demand is. They know where the surges are. They know what they need to stock more of. We don't really understand the demand in our system. Traditional methods of managing the queue are not effective and actually often make the situation worse, even though they seem like the obvious answers. Capacity is an appropriate level based on demand, and therefore to measure our demand and understand the demand. We need to reduce variation wherever possible, and that's really key. Looking at variation, trying to make things as relatively simple as possible rather than making them more and more complicated. I hope that's been a sort of very informative and useful sort of taster to demand and capacity. There's a lot of other things, and a lot of other tools we can use to start sorting this out at ground level. But I think we need to really start thinking about this issue in a different way.
Has left the conference.
I think that's given some pointers as to where we can start to look to improve the underlying problems. So again, I'll stop there for some questions. Just to know that I believe this webinar is being recorded. I will send a link out with that. I was also do a video of some of this presentation recently as well, which was hilarious, and the links to that I think are going to be sent out as well, so you'll get to see my face with it at the same time, which is, might put you off. So I'll stop there for any questions at all.
There's a question there, Richard, from Joe. Would one queue for appointments in the morning surgery, say, work better than running lots of different lists, similar to one queue in the post office?
And that's certainly one way of looking at it. You know, your patients book in. You have to, I guess,
left the conference.
Concept that would in a way work as sort of open clinics with patients just coming in and waiting in walk-in clinic kind of way. And I guess there might be a place for that somewhere. But patients do like to be booked in, and we do need to give them choice. And if we work our systems out, then there is room to manage it so that patients can book ahead at a time for their convenience and relative convenience, and a doctor of their choice. And obviously, we also have patients coming in on the day, and most of those often don't mind quite so much who they see. So that's a slightly different scenario. But I think if we're talking about a sort of sit and wait or open clinic, that sort of walk-in idea, then I'm not sure that sits particularly well with things like patient choice. But I think thinking of it as a post office queue is certainly the way to go for many things. Yeah. Somebody's put, any tips on persuading colleagues that changing the system may help? I guess that's always the tricky one, and I think it's always very well to have the right kind of information or the right data and all of that, but of course the ground has to be fertile for those nice ripe seeds to grow. I think people realise that change is necessary and inevitable. That actually a lot of this is a way of probably working smarter and work a bit easier rather than working harder and harder. From experience, as one, I think a lot of doctors like to see numbers or some proper data. So I think that can help as far as our clinicians go. But I agree, it can be very difficult, and I guess we shouldn't go like a bull into a china shop, really.
One technique to put this into the mix that IQ have used, our team have used in the past in local workshops, with practices is that we've focused on patient safety and improving patient safety and quality as a topic that engages practice teams, brings them together. And in doing that, we've looked at how you can, how you understand variation, what is variation, how you can reduce it, and almost standardise certain processes that we know could be easily standardised, but we don't always face up to the challenge. And we use process mapping as a technique, and it does open people's eyes and starts the engagement process, I think, in looking at specific processes that they thought were reliable and safe and actually aren't.
Yeah, thanks. I think when I'm talking about this normally, and if I'm certainly at a practice, I think it's really important to bring it back to the patient all the time. Often we can be guilty, and I've done it myself previously, we're guilty of almost designing a system around what works better for us as either clinicians or in the office or whatever. But actually, if we really look at it from a patient's point of view, and from the view of the patient's journey, what they want, then we're unlikely to go far wrong. I think that's probably a key as well. So David here has put that harsh truth. We don't really want to understand our demand in general practice because he's put we as a profession don't really want to deal with the problem, change the way that we work, deal with the real demand. Yes, I quite agree with that. I think there is that hesitance of actually of making change, of doing the change. We're very good at talking about it and coming up with action plans, but actually truly dealing with it is difficult. And I think again, because we understand the demand, then we just come up with sort of anecdotal solutions. So I quite agree. I think there is a hesitance there to try and understand it because, or deal with it because we don't necessarily want to know what the problem is. Another question here about one long callback list, with doctors taking patients off the list for calls and then dealing with on the phone or arranging a face-to-face appointment. Definitely does help. I think for patients you can deal with that, certainly for calls, for visits, and for that kind of thing. Patients, of course, want to speak to their usual doctor, then that can be highlighted, of course, quite rightly. They may have to wait a little bit longer. Let's take this back to a post office queue. One long queue for everybody, unless you have a particular issue, so there may be a separate desk for, for currency or for especially big parcels or something like that. So you have that way of coming off the sort of conveyor belt. And not everybody has commonality, but most of our patients can go through the same sort of path. So yes, having a single list for things like callbacks or visits is very sensible, unless the need as far as choice or continuity goes, I think. So we have to think about, we can't simplify things too much. And again, comment here about sort of potential gain in quotes that individuals have in their current systems and how this can be a barrier to change. Yeah, and I think that's true. Again, I think people like to, some people can thrive in the way we are at the moment and, worry about change. All of us do. And I think resistance to change.
Ask the conference.
And again, about working with single callback queues and things like that, and how would we deal with the fact that clinicians don't work at the same speed and capacity and quality? Well, quality work at the same quality or similar or within a sort of acceptable limits of quality then that's a separate thing.
Left the conference.
Whether we work at the same speed or not, then I guess internally there has to be agreement to how you're going to do that. You just accept that, and do the clinicians who work a bit slower have to work longer in order to see the same patients, or do you just all say, right, we're going to do 2 each, and we're just going to go on until we get them done? And the way is really that through that list sort of thing. But I think that has to be discussed wherever you are.
There's a question from Mark, Richard. Is there a danger that segmenting GP appointments into normally well and patients with complex long-term conditions will become carve-out?
Still, that is yes. But necessarily know what the normally well patients are coming in with. So again, we're cutting them out on and we're dividing those bits into normal segments. If we know, having measured it, that our patients with complex long-term conditions are going to take, say, 20 minutes, or we're going to take 20 minutes in general, and most of our sort of normal well patients are generally going to take 10 minutes, then you would then, yes, that becomes a stream or segment, because you're streamed by time. But if they're going through exactly the same process and they're all talking about the same time most of the time, then it's a carve-out. If we know that they're taking longer rather than just anecdotally think they are, but if we can actually show that they're taking longer, or a certain group of patients are taking longer, then it's probably correct to give longer appointments. But again, if you start chopping your capacity into appointments and short appointments in blocks, then you come into problems as well. No easy answer.
We've got quite a few comments in. I know David's just sent another comment that I hope everybody can read on the screen. I'm conscious that Richard and myself are doing quite a lot of the talking. If anybody wants to speak, we will unmute you if you raise your hand and press that button at the bottom of the column where the names are that says raise hand, and then we can have a discussion. Mark got a question.
I think Mark's got a question.
Yes, thanks, Richard. It was really just following on from the question I provoking you on was segmenting into long-term conditions and normally well patients carve out. And my view on it is it probably isn't. It's probably the right thing to do to segment.
Left the conference.
But it requires an awful lot of adaptive work and test cycles to get that right. And my fear is that we have systems sometimes adopts a new way of working and then doesn't really monitor that new way of working. So we change from the 10-minute slot for everybody, and quite a few practices are thinking about, can we manage people in different ways, then a new way of working, and they don't measure demand, measure capacity, and see if it really works in practice. And could it become carved out?
Absolutely, and I think it is. I think, as you say, we tend to come to what is fundamentally a really good idea, but then sort of doing it everywhere at a great rate of knots, with actually seeing that it's actually the right way to do it on the ground. I think my issue with the way you suggested, and I think I absolutely agree with you that it is probably the way to go, though. But I think if we start splitting up, having set sort of blocks of appointments for normal well and set blocks of appointments for sort of long-term conditions, chronically unwell people, then it is carved out, rather than actually recognising which need those longer appointments and actually building that into the system. And it is complicated, and it does require a good long workup rather than just saying, as you said, if we just write anyone with a long-term condition long, anyone else short, then run into problems. It needs really looking at properly.
Yeah, and it works better is if you can look, as I know some of our primary challenge funds, some of the primary challenge fund sites are, and actually completely reworking the process, particularly for patients who are normally well, where they even need an appointment. Yeah. Can you make the first protocol telephone consultation or based consultation? It becomes a completely separate process.
Yeah, absolutely, great. John, I think, got a hand up as well.
Blind unmuted.
Hi. Oh no.
Sian from Southwark. I think one of the difficulties is around changing people's behaviour and doing that on a large scale. And I think what's happened with a lot of the access work over the last 10, 15 years is there's piecemeals of different bits of activity, and that's not really shared, and practices that aren't changing kind of staying there. And so there's something about making people understand the need to change, but also bringing people with them, doing it at scale. And I think that's something we haven't got right yet.
I think you're right. I think we saw it a lot. We saw it a decade ago in acute sector, where lots of pockets of improvement work going on, but nothing really sustainable, and nothing moved on. I think again in primary care, where work far more separately and individually anyway, then it's very hard to move that across. The little practice I told you about at the beginning of the presentation, I've heard of them before, or any work they're doing, and yet they have almost the perfect system. They sort of accidentally stumbled across how to work properly, but that's because they came at it from the right point of view. Nobody else knows that. And again, it's about that voice out there, because we need people to talk to each other.
Yeah.
Tom.
Hi, Richard.
Hello.
So I'm listening with interest to the carve-out debate. One of the struggles we have in terms of workload management is I get the idea of the kind of segmentation and the need to improve processes, but a lot of the time in primary care there's the kind of clinical work which occupies sort of 90% of all paid time, and then there's other, which is kind of admin, prescriptions, referrals, all that kind of stuff. And it doesn't, some places operate some kind of carve-out, so GPs would have, admin slots in the book. That, from what you're saying, sounds like probably not the way to go. But it's where I sort of struggle in thinking, well, I understand you've got behind the scenes, you've got to get those systems working effectively. But if you bought, let's say you buy 5 hours of a GP or a clinician's time, how do you then work? How do you work out their front end? Let's see patients and organise that sort of thing with the back end administration of all of that without introducing carve-out.
That's a good question, Tom. And I know it's a lot of places have, as you say, have sort of carved out for work, and we have sort of this we reserve time for visits and phone calls and paperwork and admin and all these other things, and
Jenny,
obviously clinical work
has left the conference.
Should and generally will take priority. I personally think the rest of it just needs to be often filtered through. If you and rather than batching it up, so for example, rather than leaving 100 prescriptions to be signed at the end of the day, why not just sort of filter them through the day? and 5 or 10 every time you walk past the pile, sort of thing. It actually just requires a different way of working rather than. But the logical solution is to save time for signing prescriptions or doing your admin or doing your legal reports or whatever. But actually, that just makes the problem worse.
I can really get there. I guess there's that sort of fundamental tension that there's sort of the accepted way of working in primary care is to sort of until you either can't make another rational decision or the work is finished for the day, and it's sort of from what you're sort of seeing as perhaps a sort of safe way of working is if you're spreading your resource of clinician through the day and they're working perhaps quads of time. So you may almost having 4 hours on, half an hour off, 4 hours on, half an hour off. Like say if you're working in A&E, you would have sort of protected breaks and all that kind of thing. But while you're working, you sort of you're working through this sort of shared amount of work, with the effective processes sort of happening behind that. But it's a big. I think that's a big behavioural shift in the way that most GPs work.
I think until recently we all worked very individually, basically, and that does not that sort of that group thinking. The one thing really impressed me at this practice I was talking about last, and I actually said to them afterwards, and this was the absolute truth. It's one of the few practices I've ever been into that I would actually really want to work at, because it just got everything sorted and their whole ethos was correct, and they all work very much as a team. They all work together. They all have the same way of working and the same sort of thought processes going on, and that's why it works. Because they're all working in their own individual rooms, sort of independently of each other. They're a team. They work together.
Cultures. Did they talk to you about the way their culture had developed, or because obviously it just happened, does it?
Wasn't really time for that, but I think 3 or 4 of them, say 10 years ago, suddenly realised that they couldn't keep on working the way they were, and they just said, right. I think one of them heard the phrase doing today's work today, and they sort of took that and ran it.
No more questions.
Richard, it's David Griffiths here.
Hi, David.
I'm just interested in lots of this, and unfortunately we had technical issues. I'm here with Tom, and we struggled to get on, so we missed it. Sounds very interesting. Your perfect practice, so we'll look forward to getting the recording. In the concept, the Stephen Covey idea of the kind of quadrant of work that's urgent and important, and there's a part in general practices that we don't really stream our work in any sort of sensible way. So everything just gets into this kind of it's urgent pile. It really isn't. So you then can't filter out, this stuff. It's just the stories of the people who wait a long time for something that is urgent because actually you're just consumed with frivolities. So is there a solution to that? What's the way to kind of prioritise work? I'm sorry I answered this earlier on.
I think it's all, and I'm not talking about urgent here. So there's obviously stuff that needs dealing with now. So in A&E we have resuscitation. That takes priority. If you don't do that now, then things happen. But I think fundamentally, if we say right, let's deal with all, rather than making some patients suffer by waiting or punishing them for coming in needlessly, if we consider that all patients are urgent and therefore we're all going to see them all as soon as possible in reason, then I think that's the sort of fundamental mindset I think we need to come at it from. We like to we have naughty chairs in A&E for that sort of group 73 triage lot, make them wait for a long time, which I know is tongue-in-cheek, but there were areas where people were told to wait and they waited a very long time there. And we just need to consider that, the patients that come in, they have a perceived need, and the best thing we can do is see them as soon as possible. But there are obviously groups that do need to be seen quickly. We'll always have to have extras slotted in, because there will be the sick children, the people with significant medical problems who need seeing straight away.
Okay, thank you.
Scarlett for Jonathan Biggs.
Has left the conference.
Say that somebody's asked me for the name of the practice, and I can't really divulge that without obviously speaking to them first and seeing if they're happy to be contacted. But I can do that.
Okay. Shall we close it then?
Yeah.
Ronna?
Okay, so I think we'll close. I appreciate that people have got homework to do. But I hope people have found that interesting and useful. Links to it will go out, as will a copy of the actual webinar. And any questions, then I'm sure we can get them through some form of official channels. Great, thanks
Claire.
so many people for giving up their lunch for that. Thank you.